Thank you, Ignacio and Pedro, for the opportunity to present at your OrtoBioMsk conference. Today, we're going to talk about orthobiologics of the lower limb. I'm going to briefly share my story and our medical practice in Los Angeles, some treatment and protocols, and go over some basic cases that we see on a regular basis of the lower extremity. So I have a bit of what you call a pioneering spirit. Before medical school, I used to travel around the world and find unique cultures and just see a little differently ways to look at culture and question the way things are being done. And so I think that translated into orthopedics and questioning the use of steroids and some of the conservative treatments that had shortcomings. So in 2007, I was introduced to the concept of using the body's own ability to heal itself with platelets and cells, as our colleagues in Spain were using on professional footballers. For an MCL injury, we treated a player with a great result. Subsequently, I tried surfing in Los Angeles and injured my own MCL, and I became a patient, which really drew me into the fundamental aspect of the body healing itself through its own cells. I began to then publish articles, reviews, and trials of injecting plasma and blood into the knee, which in the past we thought we shouldn't be doing due to hemophiliacs, but the science made sense. Later, I felt a need to connect doctors, that we should be learning from each other and develop best practice and protocols and publish science and share our work. So I founded TOBI, the Orthobiologic Institute, in 2010, where you see just a handful of members from around the world gathered, including Spain. We had workshops, procedure demonstrations, and as you can see, as the field's grown, so has the TOBI community, with over 40 countries representing over 1,000 attendees from around the globe in just 13 years. Our practice in Los Angeles is a bit of a hybrid where we treat professional high-level athletes from all levels of sport to weekend warriors that need motion and activity and motion, to everyday patients with joint discomfort, limited mobility, or tendon pain. As we know, there's an epidemic of osteoarthritis. Following meniscus or ACL injury, there's a dramatic increase in risk for osteoarthritis. And total knee arthroplasty, while it's an option for some, it's not ideal in those under 60 with some more challenging goals and outcomes. And so we need to come up with more treatments during this gap for patients to keep them active with minimally invasive therapies. So when we look at some of the toolbox that we have in our practice, our mainstay treatments are PRP, which is either intra-articular or intraosseous, bone marrow concentrate, microfragmented adipose tissue. And then we're really excited about using machine-based energies to stimulate healing, much like injecting cells. We use mechanical-based energy to stimulate the body's own inherent ability to self-heal, including shockwave therapy and electromagnetic energy. Our practice is unique in that we capture data on all our biologic cases. Using a patient registry, we can benchmark and track our outcomes, tease out, are we getting better results with shockwave plus PRP or combination therapies? It's important when addressing the knee to see it as a complex organ. We don't believe in a simple, we call dump and go injection, where you just inject intra-articularly. We feel that we're not targeting the knee as a complex organ as a whole. So we have to look at the extra-articular, the soft tissue, tendons and ligaments, and some of those nerves surrounding the cutaneous sensory nerves, as well as the intra-articular joint environment and the cytokines floating through the joint pathology, and then subchondral bone, intraosseous. So trying to target all three is really important. Some basic protocols of our office: when we're treating mild to moderate osteoarthritis, we use intra-articular PRP. These are done for a series of 3 visits, usually at 1 or 2 week intervals, ideally. These are all ultrasound guided in terms of our injections. We treat the knee comprehensively. I may target a degenerative meniscus, the MCL. I may target the retinaculum of the patella, the lateral collateral ligament, drain a Baker cyst, whatever's needed that we believe are symptomatic and supportive will do. We use a PRP that is leukocyte and red blood cell free, and we activate with calcium chloride. If we see moderate to severe osteoarthritis, we feel that PRP is not as effective. And so we'll often recommend either bone marrow concentrate, which we add hyaluronic acid and plasma concentrate. We'll take a hemo concentrator and remove the water from the PPP of the marrow, which we believe yields valuable anti-inflammatory proteins, including protease inhibitors. Otherwise, we'll consider microfragmented adipose tissue plus PRP. And when we decide between these two, while we know from a published work of Mountner, the results are fairly equivocal, we'll gauge based on the patient's age, body habitus. If they're apprehensive of a marrow harvest and prefer fat, we'll decide between the two. And we do track our outcomes. If the patient has severe osteoarthritis, grade 4, with or without bone marrow edema lesion, we often recommend intraosseous injection, where we feel we need to target that joint as a whole versus just injecting in the intra-articular environment. We need to target subchondral bone. So with this protocol, I activate the PRP with calcium chloride, which helps it form a gel. And then I'll mix that with my BMC. And so I'll use approximately 5 cc's of BMC plus 3 cc's of activated PRP intraosseous. And then I'll inject intra-articular BMC plus HA. And if we're injecting fat, we never inject fat intraosseous due to fear or precaution of a embolus. And so the fat and PRP gets injected in the intra-articular environment, and the intraosseous is PRP, which is activated. And again, we'll determine fat versus marrow based on some of these factors described. All of our patients receive shockwave plus EMTT, which is an electromagnetic energy that we're not going to go into for today's talk, but much like injection stimulates the body's own cells and boosts the body's own MSCs and anti-inflammatory properties, much like injections can. We also use a topical CBD to get patients feeling relief better to rehab faster, as well as compression sleeves and heat. When we look at tendons and tendinopathy or tear, if they're mild to moderate, we recommend PRP, a series between 1 to 3 treatments, usually spaced around 3 to 4 week intervals apart. Same PRP formulation, leukocyte and red blood cell free, activated with calcium chloride. While there is literature supportive of tendinopathy using leukocyte-rich PRP, and we've been some of the principal investigators in the lateral epicondylitis trial, anecdotally in clinic, I like my patients to have limited inflammatory response and more of a gradual healing cycle. So I'll often recommend this protocol. Rarely in our practice, but if a patient has severe tendinopathy or they fail traditional PRP, we'll then recommend bone marrow concentrate or MFAT, or if the patient has a large tissue defect, MFAT may be desirable as a scaffolding. And again, all patients receive adjunctive modalities, including shockwave, EMTT, CBD topical, and compression sleeves. So I just wanted to run through a handful of some classic cases that we see in our practice. And it just gives you a sense of what we do. Obviously, these are not incredibly scientific and not worthy of publication, but it just wanted to give you an insight. And Ignacio and Pedro asked to share what we do in our practice and what we see on a regular basis. So this first patient is a case of mid-portion Achilles tendinosis in a 53-year-old male businessman. He's had it for about 1.5 years. He did months of physical therapy with no improvement. He tried laser. He avoided activity. He couldn't run, couldn't play paddle tennis without any relief. So he came in for an ultrasound that showed moderate thickening of the mid-portion Achilles tendon with no tear. So our plan was PRP 2 to 3 times at 4-week intervals. So what we do is I tell patients, we date before we marry, and we see how willing your Achilles tendon is to improve and heal. But based on the type of injury and how long it's been, you may require up to 3 injections. And so we also combined shockwave plus EMTT for 5 weeks. And this patient did quite well. He did require 3 injections and became pain-free with no limitations. And the nice thing in my clinical experience with Achilles tendinopathy is when we treat these patients, they don't come back. In the 15 plus years, I haven't had an Achilles tendon patient have a recurrence of the same injury, but we do want to make sure we fully treat them and get them to fully heal before they have a chance of recurrence. And so this is our technique, which varies. The literature has been mixed on Achilles, so it's important to have the proper technique. So here you see we infiltrate longitudinal in plane along the fibers of the Achilles tendon. We infiltrate 8 cc's of what's called fraction 2, which is your main PRP, in the Achilles tendon with an 18 gauge needle. Sometimes I'll often use subcutaneous dextrose solution if there's some point tenderness along the sural sensory nerves, where these can be helpful to provide some immediate analgesia. We'll use subcutaneous lidocaine and not go into the actual structure, and we dilute it with normal saline and bicarb so it doesn't burn, is less toxic. You can see I do a second infiltration here to the paratenon. So I look at the Achilles posteriorly and cross, and I floss my needle back and forth, almost mimicking to a scraping-like surgical procedure with my 18 gauge needle, breaking up some of the neovessels, and I infiltrate it with F1, which is more of a platelet poor plasma. The second study is a case of a degenerative meniscus tear, and this is a 66-year-old female college professor who had gradual onset posterior medial knee pain for about 3 months. Her MRI showed posterior horn degenerative tearing with abnormal tracking, suggesting of patellofemoral syndrome and mechanics. So she was diagnosed with this degenerative meniscus tear and underlying patellofemoral syndrome. So we provided PRP in our protocol for meniscus tears, much like our colleagues in Spain with Sanchez and Fizidol, is to do a series of 3 PRPs at 1 to 2 week intervals. The first week and the third week, we infiltrate intra-articular and into the meniscus, activating the PRP to provide as a fibrin-like sealant to that meniscus that's unstable. The second injection in the middle is just intra-articular. We also provide shockwave plus EMTT series with a home exercise, and you can see this degenerative meniscus tear over here. And this patient did really well, pain-free with no activities, and most importantly, avoided arthroscopy and meniscectomy, which we know can potentially accelerate their arthritis by lacking that cushion. This next case is a case of severe knee osteoarthritis in a young individual with bone edema. This is a 39-year-old male businessman who had lateral meniscectomy years ago and subsequently developed grade 4 lateral compartmental arthritis with bone edema, a Baker cyst, and a suprapatellar effusion. So previously he had done HA that had helped him for a year or two, but then much like many patients, he plateaued and didn't get the same like of relief. And so we progressed his plan to doing intra-articular microfragmented adipose tissue plus PRP plus intraosseous PRP, which was ultrasound guided. We also used shockwave and EMTT, which have been shown to help with subchondral bone edema and inflammatory responses from osteoarthritis, along with a home exercise program. And here you can see where he's lost his almost entire lateral meniscus that's been resected versus medially, and some patchy bone edema. Typically, we don't get post-op imaging, and it does take quite a while, we find, for bone edema to lessen on MRI. But this is an example of 1.5 years later, this patient came back significantly better, where he's able to do his daily activities pain-free. He works out with a trainer, but he's still looking for further benefit. And we do tell our patients, you will require some type of maintenance therapy between 2 to 5 years following your treatment, that our goal is not to regenerate the cartilage. We're not able to do that presently, but if we can potentially halt the disease process and improve your pain and function naturally, that's what we're going for. So my patients in our community understand that we look between 2 to 5 years in terms of treatment. And so here we do see some improved bone edema here at the lateral tibial condyle. Case 4 is a professional NBA basketball player who had chronic knee pain and a chronic bone marrow lesion. This is a 7-foot basketball center with chronic knee pain, missed a lot of the previous season, had in the past a history of MCL sprains in college, also had a recent left knee ankle arthroscopy with debridement. Shortly after, while doing rehab, worsened the anterior knee pain going up for a shot, and then did some rehab, stepping off a box, aggravated the anterior knee, had been limited, unable to play for about a year. So you can see his MRI with subchondral bone edema here. at the trochlea, showing full thickness defect. He had a shallow groove on MRI and moderate bone edema, as well as chondromalacia of the patella. So he had received PRP plus A2M, alpha-2 macroglobulin, and hyaluronic acid through another provider. And he did get some partial relief, but nowhere near the rigor of returning to an NBA season. And his goal was to return and sign in season with an NBA team shortly afterwards. So because we didn't have a lot of time for this individual, we elected not to do intraosseous, and we did intraarticular BMC plus plasma concentrate and hyaluronic acid, plus very high energy shockwave, which has been shown to be successful at high energy levels for bone edema. He did them 2 to 3 times a week, and he was sensitive to the potency of the energy, the discomfort. So we used oral nitrous oxide to allow him to tolerate high levels. And this was a very successful outcome where he received his BMC on December 17th, 2020, and then he signed with the team on April 20th and was able to participate in the NBA playoffs at a very high level. Last case discussion is a younger individual, which is more of a complex where we got to play detective and treat the unit as a whole, pelvic dysfunction. 25-year-old female with chronic bilateral hip pain for 4 years, worse with driving, couldn't really be active, couldn't do Pilates, despite physical therapy and activity avoidance. Her pain was fairly widespread at the lateral aspect of her hip, the groin, the anterior hip, and she had tenderness and some instability at bilateral sacroiliac joints. Her MRI showed cam impingement with some dysplasia, mild hip arthritis, anterior superior labral tearing of mild degree with gluteal tendinosis and low-grade partial tearing and soft tissue edema. So these can be overwhelming in some cases, but we comprehensively targeted her bilateral hip joint and labrum with 6 cc's of PRP. We targeted the gluteus medius bilaterally, the sacroiliac joint bilaterally with 2.5 cc's of PRP. Same protocol, no white cells, no red cells, activated with calcium chloride. And we also did shockwave plus rehabilitation for her. And she had pain-free recovery, returned to ADLs and Pilates, very happy. So it's just an example of someone who failed traditional therapy and was really not a great fit for major invasive surgery. So overall, there's this trend we're seeing where we're going to use this triad of injections, which are intraarticular, intraosseous, machine-based energies, including focal and radial shockwave, and electromagnetic energies to also stimulate cells. So I'd like to close in inviting you all to please consider attending our annual TOBI Regenerative Medicine Conference. It'll be in South Florida. Several faculty from Spain will be participating and sharing the latest research. And we'll have workshops on shockwave. We have lab certification on PRP, BMC, adipose tissue, spine, and intraosseous training. And it's a great collaborative environment. Much like you're coming to this event at OrtoBioMsk, we hope you can come to TOBI, and partnerships like this are really important. Thank you so much and have a great day.